I would like to thank the conference organizer in asking me to give this talk. I will start out by talking about early diagnosis and then followed by same-day ART. Let's talk about the benefits of early diagnosis. Certainly, if you can be diagnosed early, you'll be treated early. Once being treated, that person will not get sick or die from HIV infection. There's less chance of transmitting HIV and TB to the others. And if you really diagnose early, there's possibility of functional cure. Lastly, life for doctors will be easier because they don't have to be worried about differentiating from TB from other conditions. However, to benefit fully from early diagnosis must always be accompanied by rapid ART treatment, so-called test and treat. What is the definition of early diagnosis? Around the world, high CD4 is generally considered as the most reliable marker for early diagnosis, although its rate of decline depends on the viral load. Baseline CD4 of less than 350 is generally accepted as early diagnosis. However, before reaching 350, it takes average of 5 or more years, so it's too late. Too many people are already being infected by that person. Therefore, for practical purpose, early diagnosis is diagnosis made as soon as possible after HIV acquisition or after risk exposure. Around the world, many people are diagnosed late, can be either less than 350 or even less than 500. This just to show you the mean CD4 before treatment in Thai patients. Half of them are less than 200. So it's really, really late. Even 7 years after the treat all guidelines in Thailand, people are still being diagnosed late. In order to diagnose early, you need to have the patient who come up for the test early because of his or her risk perception. Or doctors advise the patient to come to test early once the patient come in for HIV, for acute HIV symptoms, but usually misdiagnosed as URI or viral infection. In fact, many patients know that they should have HIV testing. That's why they come to see a doctor, but the doctor said they have URI. So doctors must be more aware about acute HIV infection. Besides coming up for test early, you also need a sensitive test in order to diagnose early. So what is the most sensitive test available so far? Certainly 7 to 10 days after viral entry, you may not have anything to diagnose people, but later on, you will have viral HIV RNA, P24 antigens, and antibody testing. This just to magnify the time sequence of various tests coming up after HIV infections. HIV RNA is the earliest that it will come. It will be positive about 1 to 2 weeks after viral entry, followed by P24 antigen, which will be positive 2 to 3 weeks after viral entry. And then antibody, it will come at 3 to 4 weeks after viral entry. So HIV RNA is the most sensitive test. However, it's not widely available. P24 antigen is the next sensitive test, but also not widely available. So what is available now is a 4th generation of antigen antibody test devices, which can be machine-based or can be rapid tests. 3rd or 2nd generation test devices should no longer be used anymore as a screening test, either in the laboratory or as a self-test, because 4th generation rapid test is now available. Although the price is too high, but we should probably force the price down to the same level as the 3rd generation test. This just to show you the study that we did in Thailand, using 50 store samples of those with acute HIV infection, who are positive with 4th generation machine-based testing. They are all negative for antibody tests, but they are positive for HIV RNA. We use allele HIV combo, which is a rapid fourth generation test to detect the 50 samples. As you can see, 1/4 of the samples still cannot be detected by HIV allele HIV combo. However, 3/4 of those missed by antibodies can be detected by allele HIV combo. So even this rapid test less sensitive than machine-based, but it's much better than a third generation antibody testing. If we just look at the antibody test itself, allele HIV combo is still more sensitive than the conventional antibody testing, because they can detect 22% of this sample, so it is missed by antibody testing. Therefore, in the setting with high HIV incidence, where machine-based fourth generation test is not always available, rapid allele HIV combo is preferred as the first test in HIV testing over the third generation antibody testing. We must replace the conventional antibody test with this rapid HIV fourth generation test if the price is equal. Then how to get people tested early? Public education and public campaign are important, as we know, but not enough. Skill of self-risk assessment is also important, but usually biased for self. Attitude towards a healthy life, such as that use U equals to U, the same thing as having fasting blood sugar check to prevent over diabetes. This is also incentive for people come up for the test. Any legal or social barriers of risk behaviors have to be removed, and stigma, discrimination of testing and being positive also have to be removed before people can show up for testing. Convenient and kind-friendly testing facilities and testing procedure, for example, 1 hour testing, should be implemented. Multi-service that is under the same roof. For example, anal pap smear, STI screening, and gender affirming and harm reduction services should be the same roof as HIV testing. Certainly, HIV self-test is important. I'm going to talk more about testing led and provided by peers of the key population themselves. So-called key population-led health services also very important in having early HIV testing. KPLHS, key population-led health services, is a set of HIV-related health services focusing on a specific population of key populations. Services are needs-based, demand-driven, and client-centered. And they are delivered by trained and certified lay providers, which are most often, they are members of the key population themselves, so there's no stigma and discrimination. KPLHS can fill several gaps of service to key populations. For example, acceptability, accessibility, availability, and quality. Because it is located at the hotspots with flexible service hours. There are several tests available according to need. For example, hormone monitoring, STI. It's also acceptable because they are run by members of their communities. So there's no stigma discrimination. And they are well qualified and being certified by health authorities. So they cross connection with the health facilities. They are very effective in reaching high-risk people, as you can see here. They reach MSM with a high incidence, reach male sex worker with high incidence. As compared to 1,000 hospitals in Thailand, these 10 community health centers in 6 provinces could detect up to, could perform up to more than half of all HIV testing among MSM and transgender women in the year 2018. And also diagnose 1/3 of the all HIV diagnosis among MSM and transgender women, as well as distributing PrEP more than half of the PrEP distribution throughout Thailand. So they are very effective in doing this. Tangerine Clinic is also another KPLHS examples, services for transgender people. They offer hormone counseling. They also offer sexual health services like STI screening, even neo-vaginal examination. People who have neo-vagina, it's very difficult to find a doctor to examine the neo-vagina. So this service is open for them, as well as mental health consultations and also legal actions that this clinic can provide. In the last 6 years of the operation of Tangerine Clinic in Bangkok, almost 4,000 transgender people received the service. The majority of them certainly are transgender women. 95% of people who come at the Tangerine Clinic agrees to have HIV testing. 37% of them are first-time testers. 10% of the test is positive, and all of them were involved in care and with good viral suppressions. However, among the 90% of those who tested negative transgender women, only 18% of them agree to receive PrEP, which is too low. Now, let's talk about same-day ART. The benefits of same-day ART, we all know about less transmission and normal lifespan. But the most important thing is reducing the chance of loss to follow-up. If the medication can be given the same day the patient is diagnosed, rather than to ask them to come back next week or weeks after. I would like to talk more about U equals U, because if you can be treated early, they can reach U equals U faster and enjoy more on physical and psychological benefits of U equals to U. U equals to U are the facts, not myths. It's evidence from 3 zero-discordant studies, 2 among MSM and 1 among male and female, where the infected persons had been treated and viral suppressed, so undetectable. The seronegative couples will follow every 1 to 2 months with record of sex frequency, condom use, and HIV testing. After 1.5 years average of follow-up, or equal to 3,000 couple years, even they did not use condom, no more than 100,000 condom-less sex act. No one was infected by the infected couples. Therefore, understanding U equals to U will enhance acceptance for HIV testing, acceptance of HIV treatment, HIV disclosure, autonomy of sexual act, which does mean that always mean that no condomless sex, and can also reduce self and public stigma. So this message, the healthcare providers needs to understand it and regularly communicate with their patients. Then how to start same-day ART? National guidelines must recommend same-day ART if possible. And with the treat all guidelines, which all countries are now following, already allows same-day ART initiation without having to have the results of CD4 or other laboratories, even chest X-ray, provided the patients are so-called asymptomatic, which about 80–90% of the patients that we discovered every day, they are asymptomatic. Only exception is TB and crypto meningitis. Doctor must be in place, but not necessarily to be infectious disease doctor who can authorize the first 2 to 4 weeks prescription of ART via telemedicine to the nurse or to the CBO, who are the one who first encounter the patient. On-site chest X-ray may help, but not absolutely necessary. TLD is the preferred regimen because there's no problem with resistance. However, patients need to come back in 2 weeks to review all the test results and any adverse effects of ART before placing on the regular ART treatment. This is to show you the flow diagram. When people walk in at the ART site, those doctors, nurse, psychologists would then see them, looking at this confirmation of the test, psychological support, and examine them physically to find out whether or not they have TB or cryptococcal meningitis. And then just give them 2 to 4 weeks of ART supply. Ask them to come back 2 weeks later. If the test is abnormal, nurse would call them next day, not wait until 2 weeks. And then everything is okay. They will be placed on a 3 to 6 month supply of ART, and also will help them to locate the site that they would like to get a permanent or continuous ART treatment. It's important to see that the new WHO recommendation saying that pulmonary TB is not a contraindication for same-day ART. However, TB meningitis is the contraindications. Whoever is suspicious of pulmonary TB, ART can be given immediately. However, there should be follow-up in terms of rapid investigating of the TB, and then treat them properly if it turns out that we have pulmonary TB. So cryptococcal and tuberculous meningitis are the only 2 contraindications to start same-day ART, because this will cause more mortality. Just to show you example of same-day ART in Bangkok, 90% of patients in Bangkok agree to have same-day ART, and about 80% of them can be put really on the same-day ART. But in the provinces, the acceptance rate is much lower, and the success rate for same-day ART is only 64%. This to show you the day of starting ART in the various provinces in Thailand. For example, if starting on the same day, the score is 11. Starting on one day, the score is 10, 9, and 4. The right-hand side, you will see the average performance score per patient, which ideally should be 11. Everyone could be put on same day. But you can see it's 4 or 3 or 5 only. So there's a need, there's lots to do. Tips for same-day ART initiation. I think this is very important. This is a perspective from healthcare providers who have been successfully implementing same-day ART in Thailand. They mentioned like this: same-day ART is feasible if all healthcare providers in the ART clinic have the common goal of same-day ART. Coordination within the ART team is essential, as well as reduce self-esteem or self-centered by focusing more on patient-centered. A good and effective follow-up plan after ART initiation will ensure prescribing doctors that any adverse events will be detected immediately and will be managed properly. If these 3 factors are met, same-day ART can be implemented in any big or small hospital or clinic, or even a community centers. In order to achieve same-day ART, you need 3 things: demedicalizations, shifting the task of a doctor to nurses, to community or lay providers. It needs to be simplified, make things easier, cheaper, more accessible, and also differentiate according to the need of the persons. Some people may need more attention by the doctors, while some may not. Summary: patient awareness of HIV risk events and the benefit of early HIV diagnosis are the prerequisite of the patient to show up for HIV testing early. Client-centered testing services that not stigmatize people is needed, such as those operated by key populations. The most available sensitive test platform, in this case, HIV RNA, or the fourth generation test should be used without the fear that the the reactive screening test cannot be confirmed. This is the thing that many technicians are afraid to tell the doctor that the patient is really positive or negative, because the confirmation can come either later or sooner. Not today, will be next week. All the third generation tests currently used in many small laboratories should be replaced at least by the rapid fourth generation test, because it's much more sensitive. We must collectively force the price of the rapid fourth generation test down to be equal to the third generation. Once diagnosed, ART should be started on the same day. This is feasible because 80 to 90% of patients are asymptomatic, and with the use of telemedicine, with a more effective team effort. Such an approach of early testing and same-day ART will maximize the value for the money invested in the national HIV testing and ART program. So each country will benefit from doing so. Early diagnosis followed by same-day ART and same-day PrEP is the only hope that country can end AIDS on time. Thank you for your attention.